This presentation will outline the steps involved in the mini-open pedicle subtraction osteotomy. Pedicle subtraction osteotomy represents a powerful corrective tool in the deformity surgeon's armamentarium, affording up to 40 degrees of sagittal correction. It is particularly useful in cases of fixed flat back deformity, such as in previously fused spines, or in the presence of a sharp focal angular deformity. However, traditional PSOs have been associated with high complication rates. The mini-open PSO, first described by the senior author in 2014, combines the established open technique with MIS principles, leveraging the benefits of both. Since then, the mini-open PSO technique has been incorporated into various adult spinal deformity surgery algorithms as a powerful MIS tool in correcting severe sagittal deformity. PSO is a V-shaped osteotomy traversing all three columns of the spine. Closure of the wedge restores lordosis and achieves realignment in the sagittal plane. Through a single midline skin incision, the fascial envelope is opened and subperiosteal dissection performed only at the site of the PSO, thereby limiting extent of soft tissue disruption. Surgery then proceeds in standard fashion, with liberal central decompression above and below the osteotomy site, with bilateral facetectomies and skeletization of both exiting and traversing nerve roots. Following this, the transverse processes are disconnected from the lateral vertebral wall. Subperiosteal dissection along the lateral body is then carried out ventrally and maintained using cottonoids or specialized retractors. Under fluoroscopic control, decancellation osteotomies are then performed through the pedicles into the vertebral body, using a combination of curettes at increasing size, osteotomes, and high-speed drill, meeting across the midline. Any residual pedicular wall can be excised with rongeurs. The nerve root and thecal sac are medialized, and the PLL incised, and the posterior vertebral wall is pushed into the osteotomy defect using reverse angled curettes and removed, thus eliminating any potential for ventral compression following osteotomy closure. Harvested bone is saved for later fusion. Pedicle screws are inserted in a percutaneous or perfascial manner using MIS technology, at least 3 levels above and below the PSO site. The spine is controlled using rostral and caudal rods passed through and secured to screws either side of the PSO, meeting and engaging via side-to-side domino connectors, thus preventing translation. The osteotomy is closed by manipulating the rods and reduction maintained by final tightening the domino connectors. The neural elements are directly visualized during and re-inspected following osteotomy closure to avoid undue buckling and ensure adequacy of decompression. Using the mini-open and 4-rod cantilever techniques, we have been able to achieve powerful realignments in both sagittal and coronal planes while adhering to MIS principles. The quad-rod construct may additionally reduce the incidence of rod fracture. To minimize complications, a number of measures should be considered, including intraoperative neuromonitoring to detect and remedy neurological decrements, adequately decompressing above and below the PSO site, and reassessing after osteotomy closure, including the exiting and traversing nerve roots and ventral surface of the fecal sac. Controlling the spine with rods prior to final vertebral wall resection or fracture to prevent translation. Attention to fusion must also be paid, including off-label use of biologics if necessary. Meticulous hemostasis imperative, including use of topical hemostatic agents to minimize blood loss.